So let's get started. So hem-onc emergencies, let's just run through this pretty quickly, since this is probably the things that we are most comfortable with seeing and treating and evaluating for. What page is it, Lacey? 51. So a patient with back pain, heaviness of the legs, progressive motor weakness, hyperreflexia, incontinence, you're worried about cord compression, right? Spinal cord compression, and somebody who has a history of malignancy, you especially need to have this high on your differential. How are you going to acutely evaluate and manage that patient? Steroids, MRI, neurosurgery consults always, an option. But steroids, MRI is going to be your first thing. Usually 10 of Decadron at first, 4 Q6. The MRI, you're going to order stat. So say you diagnose cord compression from a malignant lesion. What are your 3 options? Surgery, chemo, radiation, right? So which one is going to be the most commonly utilized? Radiation. Right, that is going to be your go-to more often than not. There's only going to be a few instances where you would say chemotherapy is going to work super fast enough that I feel comfortable using that as my modality. So for example, small cell, right, is really chemosensitive. What are reasons that you would go to surgery to manage cord compression?
Severe or rapidly progressive symptoms?
I would say severe in the sense that they have possibly an impending fracture or spinal instability.
Something potentially rescuable?
Well, because hopefully the radiation would help that too, right? The steroids acutely, the radiation could help with some of that. But the reasons that you were going to be saying, I'm going to be doing surgery and not radiation, is spinal instability and if you need a diagnosis. Right? If you don't know the tumor type, what kind of tumor it is, then you would need that information to help guide your decision in treatment. As we're talking, let me erase this. We can create a little list, right? The catchphrase is you need meat before you treat, right? Tissue is the issue. There's going to be a few instances, right, where you can treat before the meat. Right? Does that make sense? And so we will have this running list over here. And then I think it's good to also create a list of our tumors, of kind of early stage tumors or masses versus locally advanced / maybe some positive lymph nodes, and then thinking about the management in metastatic disease, right? So for each thing that we talk about, we can kind of break up our management quickly into this. Does that make sense? Headache, nausea, vomiting, altered mental status, papilledema, history of lung cancer, you're worried about. Brain mets, how are you going to manage and diagnose?
Basically the same. The same, MRI.
MRI and steroids, right? You want to be decreasing that vasogenic edema from those lesions to help with symptoms, and then acutely manage. And then again, treatment is going to be based on the type of tumor it is, right? Whether it's radiation, again, probably most common. If it's an isolated brain met, sometimes they do surgery in those. So the treatment's going to be a little bit varied based on the underlying diagnosis. Do you give this person empiric Keppra to prevent seizures? No, even though you see neurosurgery do it here all the time. Brain met with no seizures does not equal Keppra yet. Swelling of the neck, face, arms, cough, dyspnea, headaches. You see plethora on their chest, plethora on their face, collaterals on their chest wall. They have SVC syndrome. Your diagnostic test of choice, if you think somebody has SVC syndrome, is a CT chest with contrast. You can miss it on a chest x-ray in like 20% of the time. So a normal chest x-ray does not rule out a mass causing SVC syndrome. It can be hiding in the mediastinum. How do you acutely manage? Usually there's not too much that you would need to do immediately to help this patient, other than, right, getting your tissue so you can definitively treat. Polyuria, polydipsia, confusion, nausea, vomiting, constipation, altered, short QT. You think they have hypercalcemia. Their hypercalcemia could be due to a couple of mechanisms from malignancy, right? What are those mechanisms? PTHRP, right? Kind of direct bony destruction like myeloma, metastatic disease. And then what about in our lymphoma patients? Yeah, right, kind of increased active vitamin D. So in these patients, acutely, how do you acutely manage their hypercalcemia? Fluids. What kind of fluids? Normal saline. How much fluids? A lot. Yes, a lot of fluids. Do you do diuresis? You can if after you hydrate, right? These people are super dry. They've been having diuresis probably for a while from the calcium. So really diuretics are not going to be that helpful. Sometimes your hand is a little bit forced if somebody has heart failure, right, and signs of volume overload, and you want to give them fluids. That's kind of when you would also be following it with diuresis. How do you acutely work to bring the calcium down? Calcitonin and bisphosphonates. You're giving them both at the same time. Which one works first? Calcitonin. When does it stop working? Usually 48 hours or so. It has tachyphylaxis. You kind of just get used to it. When does the bisphosphonate that you gave at the same time start working? 48 to 72 hours. So that's perfect, right? Life all works out. Because calcitonin stopped working, but now your bisphosphonate should be kicking in. If somebody has hypercalcemia due to that vitamin D production, right, like your lymphomas, what's going to be better treatment for the calcium? Steroids, right? Right, so lots of fluids first, a lot of fluids. You can do calcitonin and bisphosphonates. If somebody has pretty significant renal insufficiency and you're like, oh, I really don't want to give a bisphosphonate, what other newer drug could you give? Denosumab. Fever in a patient who has malignancy, they're on chemotherapy, they got chemo 10 days ago, what are you worried about? Neutropenic fever. What do you do acutely? Antibiotics, cultures, x-rays, right, finding the source. What sort of antibiotics do you choose? Right, so your first thing you want to cover is Pseudomonas. That is your first goal. When do you add on staph coverage, MRSA coverage? Hemodynamically unstable, right, they're in shock. Lines, mucositis. So on the boards, right, in real life I feel like often we give both at the same time. here's your cefepime and vanc, or here's your zosyn and vanc. On the boards, if they really don't have those risk factors, they're going to want you to start with just pseudomonal coverage, give it a day or two, and if they're still having fevers, obviously if they're not unstable, then adding on vanc, right? And then if they're still having fevers by day 5, then adding on antifungal. So on the boards, they kind of like you to do more of a stepwise approach. But if somebody has risk factors for staph, like a line, right, they have a port, an IV, then start it from the get-go. A patient has Burkitt's lymphoma. They're coming in for treatment. They have an increased creatinine and potassium. What are you worried about? Spontaneous tumor lysis, so it's happening even before they've gotten any treatment. What do you do acutely to manage? Fluids, lots of fluids. All right, you want to bring the uric acid down. So you give respiricase. What condition is contraindicated? G6PD. Although at that point, I don't think you'll be saying, oh, I wonder if you have G6PD. I think it'll be after the fact on the boards. It'll be like, why are you now anemic? So pretty much everything lab-wise is going to be up, except what, right? Your creatinine is up, your potassium is, your phosphate is, your calcium is low, kind of in response to the phos. And then treating, obviously, the underlying tumor. How would you prophylax tumor lysis? Allopurinol. Fluids. Would you give respiricase as prophylaxis? When could you give respiricase as prophylaxis? Right, so if somebody already has a pre-treatment elevated uric acid plus a high-risk tumor with bulky disease, and you're like, I'm going to treat them, and their uric acid is already, kind of high. Give them respiricase preventatively to bring it down before you treat. History of breast cancer, coming in with hypotension, tachycardia, muffled heart sounds. Pericardial effusion, you're worried about tamponade. How would you diagnose this? An echo. How would you acutely manage this? Right, pericardiocentesis, window acutely, right, giving fluids, right, they're preload dependent, so you want to be upping that. And then treating the underlying malignancy. So moving on to head and neck cancer and lung cancer. I think my slides are a little out of order from your book. Find it. What page is it? 45? So let's do maybe just a couple of points on head and neck cancer. So head and neck cancer is going to present, you're going to have risk factors usually of smoking. They may have some symptoms just related to the actual lesion, or they may come in with cervical lymphadenopathy, right? So say you had a lymph node that you biopsied and it came back squamous. You're like, it's head and neck cancer. Your next step is going to be staging CTs and pan endoscopy. So they love to ask that question. You'd think, oh, I can just CT everything, or maybe have ENT just take a look, but you also need to have their esophagus looked at, and they need a bronch. Smoking, right, is the most likely cause of this, and there is a field cancerization effect. So they can have multiple tumor sites, or even just finding the primary tumor. Is this coming from an upper esophageal squamous malignancy, or is this an upper airway, is this what have you? So filling in this chart here, right, so head and neck. Early treatment, we're going to do what? Small tumor, right? So this is very early disease, surgery, right? So the mainstay is curative intent, take it out. So I'm going to do surgery. Who do we pick XRT in? When surgery is very morbid for that patient, right? This is an early stage. Surgery is going to remove their ability to talk or to swallow, right? So if it is the base of the tongue or larynx, then you would be picking XRT. Otherwise, the goal is surgery and resection. So tongue, larynx. So for locally advanced, metastatic, right? So for locally advanced, it could be a combination of a few things, right? You could try some neoadjuvant stuff to shrink things down and then surgery. So it's really kind of all three options. Chemo, there's a role for chemo, radiation, and surgery. And in metastatic, it's palliative chemo. So moving on to lung cancer, right? Highlighting the screening test, right? They are going to want you to screen and to prevent malignancies on the boards. It's going to be very important. So you will certainly have a patient that they are going to want you to choose an annual low-dose CT of the chest to screen for lung cancer. They are going to want you to identify a pulmonary nodule and when that patient should be followed up. So this is something not to burn to your brain right now, but this should go along with your biostats review, right? 2 weeks, 2 days, and 2 hours before. So thinking of their risk factors, if they're a non-smoker, a smoker, their age, I think usually they're going to give you something that's pretty cut and dry, right? A small nodule in a low-risk individual, you're going to say they're good. Versus a small nodule in a high-risk individual, you're going to do another CT in a year. So this is just something to review prior to the test. So now work up. So say now you have found a mass. How do you work it up for lung cancer? So the key here is seeing if this is early. And actually, let's separate out small cell versus non-small cell. So for non-small cell, right, so on this side of the curve over here, early, the goal is surgery, right? You've been doing their annual CTs, you see this nodule that's enlarging, they have risk factors, it's spiculated, doesn't look like there's any lymph nodes anywhere. Your goal is to say, let's just take it out, and you're good, right? Again, late stage, right? Metastatic, stage 4, malignant pleural effusion, chemo, palliative chemo. All right, with the exception that remember that if somebody has this isolated brain met causing symptoms, you can take it out to give them better quality of life. They will. Yes, they will. Yes, they will. Right? So that's a good point. Right? So in terms of chemo here, also think about tumor-specific mutations. Right? They are going to want you to say, I want to check EGFR in adenocarcinoma. And so we'll go through some of those on the questions too. But all of those are usually in this metastatic category. Tumor-specific mutational changes that's targeted to a specific drug. So the middle stage, right? So maybe they have some mediastinal lymph nodes, maybe they have large tumor. What do you do here? Right, so maybe you did surgery plus some chemo. In terms of XRT, right, you could do some XRT also for symptom management. an obstructive lesion, causing an obstructive pneumonia, things like that. In contrast to small cell lung cancer, early stage chemo, right? This is, even though you are seeing it, isolated to a radiation field, which is how they determine just limited versus extensive for your 2 small cell lung cancer stages. Surgery is really not going to be anything that you start with small cell. So even off the bat, you're starting with chemo plus prophylactic brain radiation, right? Because you know that this has a high chance of recurring, and when it recurs, it's going to come back to the brain. So you give prophy brain XRT. Right? So anything outside of one radiation field, what are you giving? Oh, and XRT here. Yeah. Right, so then this is chemo. And XRT for symptoms, right? They have brain mets, obstructive lesions, bony mets, things like that. So when you're thinking about so going back to evaluation, thinking about your evaluation of somebody with this tumor, right? You need to assess, first of all, the type, right? So that's where tissue is the issue. And you need to assess if this is early versus more locally advanced, where I'm going to be favoring just chemo, right? Especially for the non-small cell types. So the biggest thing that they want you to pick up on is staging it with biopsies. So if somebody already has a pleural effusion and you tap that and it comes back malignant, right? You've staged them at a stage 4. If somebody has a lung mass and mediastinal lymph nodes that are maybe borderline enlarged, right? They could potentially be stage 3, right? Where you're kind of getting more over here. So what do you have to do to determine if those lymph nodes are significant or not? Biopsy them, right? So back in the day, it used to be horrible mediastinoscopy for everybody. Now a lot of it's done via POEM, right, and EBUS. So that is helpful to determine which way do you think, if it's the mediastinal lymph nodes are not positive, let's do some surgery, followed by some chemo, whereas if those mediastinal lymph nodes are positive, you may be going straight towards chemo first, right? Lung cancer has a lot of paraneoplastic syndromes. The board loves asking about paraneoplastic syndromes. Small cell has several, right? So we talked about Cushing's from ectopic ACTH, SIADH, carcinoid, Lambert-Eaton, limbic encephalitis. Limbic encephalitis looks like personality changes. You could have some seizures. Keep it in your differential of HSV encephalitis on the test. So if somebody's coming in, altered, confused personality changes, and they're giving you data about HSV encephalitis and it's not panning out, you need to be thinking, is this paraneoplastic, a limbic encephalitis? Do they have small cell? The other classic one is testicular. Subacute cerebellar degeneration. It's more ataxia. Which antibodies go with limbic encephalitis? Anti-Hu. Which one goes with cerebellar degeneration? Yo, right? Because I think of somebody saying, yo, and they're like, ataxic. Yo. Right? For adeno, right, the classic one is hypertrophic pulmonary osteoarthropathy. They're going to present with pulmonary mass.
And like arthritis.
Arthritis where? Rapid onset of clubbing. And where's their joint hurt?
Toes or feet or something, ankle.
They're
Lower.
tibial tuberosities, right? So kind of right under the knee. Squamous cell, and squamous cell even outside of lung cancer, head and neck squamous cell, cervical squamous cell. You should always think about hypercalcemia in their symptoms if they're presenting with those symptoms, and it's through the PTHRP mechanism. So let's flip and answer some questions about head and neck and lung. Oops. Oh, this one has the answers. Is that okay? I can pull up the one without answers. Or maybe I can just scroll through it. Here we go. So the most important prognostic factor, I'm not sure if this one made your list, in patients with advanced non-small cell lung cancer is performance status. Right? Because you're talking about just palliative chemo at this point. It's really not going to be exquisitely helpful, so they need to have a pretty decent ECOG to get some benefit from that. Whereas somebody with small cell, advanced small cell responds so quickly to that chemotherapy that you will advance their performance status just by giving them chemotherapy. Right? You're going to shrink their brain mets really fast. They'll be walking again at that point for that period of time. But for non-small cell, you really have to assess their performance status if you're going to be giving them chemo. The lung cancer most likely to cavitate. Squamous. How can we remember that? Yeah, maybe you squished. I don't know. Squished your squamous cell, and now it's got a hole in it. Right? Squishy, squamous. Most common type of lung cancer in non-smokers, adeno. Patient with joint pain, new digital clubbing. Something on the right. There's their clubbing. Right, they have new bone formation here. Right, so you are worried that this is hypertrophic pulmonary osteoarthropathy. So you are going to astutely say, I am worried about this as the cause of your symptoms. Adenocarcinoma. So you're going to say, let's get a CT chest. A patient has a unilateral effusion. You do a thoro, the fluid comes back consistent with squamous cell. Their CT has a hilar mass. What do you do for staging and treatment? It is staged, right? A malignant pleural effusion is a stage 4 that puts them here. Right, so you assess their functional status to see if they would tolerate some palliative chemo. Here we go. In terms of imaging the head for individuals with non-small cell that are asymptomatic, you can probably wait. Patient has hoarseness, unilateral cervical lymphadenopathy, a smoking history. What's your next step? ENT stuff. So I've heard panendoscopy, ENT for scoping, panendoscopy, They're going to be needing CT scanning.
I think we need everything.
There we go. All right, so you want to biopsy the mass, right? If you can, if they're giving you other symptoms like hoarseness, they have that smoking history, and you feel this lymph node, and you're like, I'm really worried that this is head and neck, see if you can find the tumor and just biopsy that. That preserves a little bit of the neck in case they do have surgical options, right, that they want to use in terms of also kind of dissection there.
Why would you biopsy the lymph node for staging?
You could, but your imaging might guide you further kind of with staging as well. So in terms of first getting the meat, right, for the tissue, if you can biopsy something that you see, then I would say do that first in this case.
Would they scope before they get like a CT of like the head and neck?
ENT would scope. They can do that quick, but they would need then further scoping, right, with bronch, EGD.
Okay. Well, like as far as getting like a CT scan, like imaging that way, you would do the endoscopy first. Like for this question up here, where they mentioned like the symptoms that they were having, they wouldn't do like a CT of their head and neck first before endoscopy.
No, for hoarseness, I would say go ENT first.
Okay.
Right, because if they don't see anything there, right, then I would say maybe then biopsying the lymph node. A patient has truncal obesity, hyperpigmentation, hirsutism, striae, low potassium alkalosis, what paraneoplastic syndrome, Cushing's, from which tumor most likely? Small cell. Patient has.
You said the other day you can just test for that straight up. It's like the normal ACTH.
It's the regular ACTH. So unlike PTH, which you have to test a separate entity, right? Your PTH is going to be, your real PTH is going to be low because your PTHRP is going to be high in that condition. With this paraneoplastic one, the ACTH that you're testing is all the same. A patient presents with proximal muscle weakness that improves with exercise. There's no bulbar symptoms. There is no bulbar weakness. Exam has proximal muscle weakness, absent reflexes that return following isometric exercise. EMG shows motor unit potentials with increasing amplitude with exercise. What is your antibody? So which paraneoplastic syndrome is this? Lambert-Eaton. What tumor most likely? Small cell. The antibodies are easy to remember. Lambert-Eaton, myasthenic antibodies, so it's calcium channel antibodies. I think that they could ask you treatment. So obviously you're going to be treating the malignancy, but you want to be removing those antibodies. So plasmic exchange, IVIG. And then this is just a definition, right? So improvement of the reflexes, right? So you check the reflexes, you check strength testing, and then you say, do, hand grip and hold this for a couple of minutes, and then recheck again, and they're going to be better. Oh, shoot. A current smoker, small nodule, 12 months, right? So this is a chart that you will review in the couple of weeks before the test. Patients found to have limited stage small cell lung cancer. They undergo chemo and XRT. What do you recommend next? Whole brain prophy radiation, right? So we are here. They got chemo, they got XRT, right? Because remember, limited stage small cell lung cancer is within one XRT field in the chest. So you're going to give chemo, XRT, and then you also still need to do preventative radiation to the brain. No role for surgery in small cell lung cancer. How would you treat a patient with stage 2 non-small cell lung cancer? All right, so you are here. Do some surgery and follow it up with some chemo. Oh, I'm going too fast. Etiology of head and neck squamous cell cancer found in young non-smokers. Does it portend, I'll have you finish the question. Does it portend a better prognosis or a worse prognosis? Hey, just entertain me. I know it's on your paper. Better. All right, so HPV is a risk factor for head and neck cancer, right? Another reason to get HPV vaccination to our patients. A patient has a lung mass, they have memory loss, mood changes, emotional ability, hallucinations, seizures. Is there a question here?
Yeah, lymphatic encephalitis.
Anti-Hughes associated with this paraneoplastic syndrome. Thank you. Middle-aged non-smoking patient with a lung mass, which you are suspecting stage 3 or stage 4. The biopsy is consistent with adeno. What additional mutational testing are you going to perform on the tumor? EGFR. So star, highlight. They love to ask this question because it will mean that you can give them erlotinib and improve survival.
So we don't look for it in all adenomas, only in this one?
So a lot of these are really only in metastatic stage, late stage disease. So we'll be going over a few of these here, but so going back to this, what's next? GI. So colon cancer screening. Remember to assess risk factors, family history. Screening becomes earlier based on the earlier age of the family member that had disease. We're going to be talking about a couple of these other screenings in the questions. The test of choice is really going to be colonoscopy because you can also get some interventions at the same time as you are screening, right? Whereas if you do a CT colography and you see a polyp, then you still have to do another intervention to follow up that screening test. Staging wise, so talking about staging and therapies, right? So putting colon cancer here. So early stage, surgery. Say you have some lymph nodes on your CT, maybe an isolated liver mass or liver met, maybe after surgery their lymph nodes are positive on their resection specimen. All right, what does this group get for therapy? Right, so they can still get surgery, but they are going to get followed up with chemo. If you have an isolated liver met, you would take that out during surgery as well. Somebody has metastatic disease, chemo. Rectal cancer, a little bit different. So early stage, surgery. Anal cancer is a little bit different. But rectal cancer, early stage, right? Still surgery. Surgery and neoadjuvant, right? chemo, because the hope is that you can spare sphincter, right? So if this is a small tumor, here, stage 1, you can do a low anterior resection, which spares the sphincter. So for once you start getting into bigger disease and lymph nodes, you want to try to shrink it down as much as possible before you do surgery. So you can do chemo and radiation and then surgery. All right, so a lot of these other ones are surgery first, follow-up chemo. With rectal cancer, that's a little bit more locally advanced, or lymph nodes. You want to try to keep your resection at an LAR and not an abdominal perineal resection, because that means you're removing the sphincter. So chemo, XRT, then surgery. So here you see role of XRT. Do you see role of XRT with colon? No. It's not on the board. So that is what they like to trick you with. So don't be answering any question that has radiation in a patient with colon cancer. And then stage 4 is going to be the same, right? Chemo. Again, mutational testing. And then anal cancer here is a little bit different. Again, really trying to preserve the sphincter. For really most stages, you're going to be doing radiation and chemo with a curative intent. So even with an early stage, you're not saying let's do surgery. So this one's a little bit different. And then I would circle this one, right? So we're going to kind of gloss over esophageal and gastric. I don't think that they would ask you too much, because there's been, I feel like, a lot of flipping here. Now it's better to do neoadjuvant chemo XRT before surgery, so I don't think they would ask you to pick a therapy, but they're going to give you somebody with stage 4 gastric cancer, and they're going to want you to check HER2 status for trastuzumab. Right? So trastuzumab, it's not just in breast cancer, it is also in gastric stage 4. So we have a patient that underwent annual FOBTs and sigmoidoscopies every, 3 years for colon cancer screening. There is a polyp on sigmoidoscopy. What do you do? So if it's hyperplastic, you do nothing, right? It's irrelevant. One hyperplastic polyp. What if it's not hyperplastic? Say it's an adenoma. Colonoscopy, right? You need to see the rest of the colon to see if there's other polyps that need to be removed in addition to the one that you removed on sigmoidoscopy. When do you perform surveillance colonoscopies based on polyp pathology? I think your chart is already filled out, right? So I can scroll down.
Most of it. Or maybe all of it.
Yeah. So this is good, right? So these are the ones to remember, right? So I would circle this, the category of people that need a colonoscopy in 3 years, right? Because if you think about it, usually you get a polyp back, they tell you colonoscopy in 5. So who are the people that need the colonoscopy sooner at 3 years? So more than 3 adenomas, so that's nice. If you have 3, come back in 3. A polyp, any polyp that's large, so a centimeter or larger, comes back sooner. Villus or high-grade dysplasia. So circle and star this category, because this is kind of the classic one that they like to ask to see who just answers 5 years, because that's the usual for most individuals, and that's what they see most frequently. First degree relative is diagnosed with colon cancer at age 55. When do you screen? Okay. Good. You almost fell into my trap. So it's, right, going back to this, it's whichever comes first. Screen at age 40 or 10 years before the age of the index case, whichever is first. Right, so if this patient, if this family member was diagnosed at age 40, then the patient should be screened at age 30. Ah. Hi.
Are we starting screening at age 40 now?
First degree relative.
I don't think those are gonna.
What happens if the first degree relative was diagnosed at age 65?
Usual.
Still 40.
Mm-hmm. 40. Hyperkeratosis of the palms and soles, called tylosis. It's classically associated with this histology of esophageal carcinoma. Squamous. Matching. This is going to be complicated, so I'm not going to pull it up yet. Let me look at your paper. So let's match. You can use the answers on the other side, I believe, more than once. Yes. So when do you do screening colonoscopy at age 35? Start breast cancer screening at age 25 and thyroid at age 18. P10. Cowden's, it's like an FAP variant. Remember breast and thyroid also with that one. Most common site of cancer in this condition is in the breast, not the colon. Peutz Jaegers. Because in the colon, those are hamartomas. Huh? Right. But their malignant potential is outside of the colon. Phone a friend and let me know. APC gene mutation. FAP. Genetic counseling should be offered for those with 3 relatives with related cancers, 2 generations apart, and 1 before the age of 50. Lynch. Right? So it's the 3-2-1 rule. Autosomal recessive inheritance, which is unique. Screening starts around age 18. MAP. Autosomal dominant. You need to do a flex sig starting in puberty. FAP, right? So this is classic, so star this one. The other ones are a bit more rarer for them to ask you. Mucocutaneous pigmentation along the vermilion border, Peutz Jaegers, requires small bowel assessment starting at 8 to 10, MRI EUS of the pancreas, EGD colon. Peutz Jaegers. Duodenal periampullary cancer is the second leading cause of death. There's no more P10s or MAPs. FAP. Star this one. Right? Because they love to ask this question. This is probably between FAP and Lynch. These are the ones that you're going to get the most questions about. They are saying if you feel comfortable removing their entire colon and then giving them your blessing and sending them on their way, right? And the answer is no. They still need EGDs. EGDs to screen for periampullary adenomas. Lipomas, osteomas, desmoid tumors. This one's not even, it's not really on the list. It's a variant of FAP, which is Gardner's. This one is from DNA mismatch repair mutations. Lynch. Right, so making sure that you remember Lynch and FAP predominantly. Don't look. I keep forgetting. Dang. This is my follow-up from yesterday, right? So the pituitary condition associated with an increased risk of polyps and colorectal cancer, acromegaly. You are growing everything. Skin tags, polyps, jaws, you name it. A patient is status post-treatment for colon cancer. What is their surveillance plan? So they're going to be followed up with history and physicals, colonoscopies, CTs, CEAs. Good. Okay. I'll take a pause. So you're going to be getting a CEA when you see them for your assessments, a CT for the first 3 years, and then a colonoscopy every other year. Rapid eruption of truncal SKs, lesser Trello. And do you think of what conditions? Gastric. Also remember gastric, you can have acanthosis nigricans as a perineoplastic manifestation. Okay, moving on to breast cancer. Breast cancer is a huge, huge topic on the boards. So starting with screening. Screening is going to be a mammo. They are not going to ask you when to start or how frequently to do it because there's a lot of variance within kind of national organizations, U.S. Preventative Service Task Force versus ACS. They are going to want to see if you are judicious with your breast MRI on the exam and if you know when to order that and when to say, no, that's okay. So this should only be for high-risk women, right? So those who are BRCA positive, those who have had radiation to the chest, and then this last one really isn't screening. This is more in the search of adeno of unknown primary. So if somebody has dense breasts because they're a young female and you're between mammo, digital mammo, MRI, you are going to choose digital mammo, which means you get a better picture because it's newer technology. Yeah, not digital like with your fingers.
It's not appropriately named.
Digital as in like digital camera.
Because I thought that if they do a medical exam,
So a couple of questions. A couple of questions you'll get are on evaluation of a woman. who has an abnormal mammo or who has a breast mass on exam. This chart was a little confusing last year. So let's start and flip to this flow sheet, which may hopefully be less confusing. Okay, so your biopsy comes back positive for breast cancer, right? So this is the stage that we're at. You send off ERPR HER2 testing because you need that information to help determine your adjuvant therapies down at the bottom. You need to determine your local control here and then your systemic control here. So every patient gets local control, systemic control. So for local control, you need to see first if they should not have surgery up front. So this is somebody who already has metastatic disease or maybe a very large tumor that's invading the chest wall, inflammatory breast cancer. Those are the ones where you would say, let's do some therapies first to try to shrink stuff down, right? Especially if it's like a stage 3, very large or chest wall involvement. Most people are going to fall into this category. So they're going to want you to determine or kind of help the patient choose between lumpectomy with radiation versus a radical mastectomy. Survival is equivalent between the two. There are some reasons where you would choose mastectomy over a lumpectomy, right? Because you think most women would say, oh, that sounds radical, let's just do the lumpectomy and XRT, right? If somebody has a larger tumor, especially tumor to breast ratio, then you may as well do a mastectomy. If somebody has genetic risk factors, right, why leave the rest of the breast tissue in there? If somebody's already had XRT to the chest, say for Hodgkin's, they're not going to be getting more XRT to the chest, so that removes that other category. So you're helping the patient choose between these two based on their personal strategy and certain factors. And then during surgery, you need to do a sentinel lymph node assessment, right? So you inject dye into the tumor, you see which lymph node it hits first. That's the sentinel lymph node. That's the one that you biopsy, and if it's negative, you're good. If it's positive, then you need to do a full axillary dissection. This all makes sense. So now you go down and you finish up local control. If somebody picked lumpectomy, right? Don't forget to give them their XRT. They're not going to get it in the OR. So on the test, they're going to give you somebody who just had their surgery now coming to you. So you need to assume that they have not yet had their XRT if they've had their lumpectomy. So then you need to figure out which adjuvant therapy they get, and these can all be potentially additive, right? So somebody could get lumpectomy, XRT, chemo, tamoxifen, and trastuzumab, right? It's like a menu. You can get anything you want off that menu. So who gets chemotherapy? Right, so a tumor greater than a centimeter, lymph node positivity. Who gets hormonal therapy? ERPR positive. Who gets tamoxifen versus who gets aromatase inhibitors? Right, so not just age, but their menopause status. Right, because the aromatase inhibitors are not going to work well if the ovaries are still producing estrogens, right? So you give them tamoxifen or aromatase inhibitors. If somebody starts premenopausal and starts with tamoxifen, you can switch them to aromatase inhibitors. Aromatase inhibitors are more successful and better. And then who gets trastuzumab? HER2 positive. I don't think they would give you somebody with a teeny tumor, right, like a 0.2 centimeter positive tumor and tell you not to pick trastuzumab.
Premenopausal gets
Tamoxifen. So then this chart, right, to interpret this chart, Mammo or ultrasound, you did FNA and core needle biopsy, it was positive. So you're choosing between breast conservative therapy or radical mastectomy or going to chemo, right? So locally invasive, inflammatory breast cancer, metastatic disease. So this is usually stage 3, stage 4. This person could then go back and get radical mastectomy, right, if they were coming to chemo first for tumor size or chest wall invasion. Between these two, right, everybody gets sentinel lymph node biopsy, and if it's positive, a complete axillary lymph node dissection. If somebody has already clinically involved lymph nodes, right, matted lymphadenopathy, you don't need to do the sentinel lymph node biopsy. You can just go straight there. You can add radiation therapy to somebody who had a mastectomy, right? So it's not always the key. It's always over here. It could be a potential over here for a large tumor or a lot of lymph nodes. I don't think that they would necessarily ask you that, but I'm just telling you that it's not, a yes or no. There is still potential to add in radiation for higher risk individuals who get a radical mastectomy. So then looking at this by stage down here, right? So all of this is therapies that then bring you to medical therapies after. So a stage 0, right, or in situ, you would still do probably more lumpectomy radiation, and then coming down here, and you can get hormonal therapy if you're ER/PR positive. Stage 1, smaller tumors, and trastuzumab probably should be over here as well if you're HER2 positive. But even for a stage 1, 1 centimeter tumor, right, that buys an individual chemotherapy. Does this make sense? Okay. And then talking about the therapies down here, knowing the side effects for tamoxifen, right, thromboembolism, endometrial cancer. So if somebody has a contraindication to tamoxifen, but they're premenopausal and ER/PR positive, you could use ovarian ablation to allow you to give an aromatase inhibitor. So aromatase inhibitors don't block the ovarian estrogen production. That's just why you have to use it in postmenopausal women. They really don't have all of those side effects. The biggest side effects is going to be osteoporosis. So you're going to be screening them with DEXAs. They can have some arthralgias that you treat with NSAIDs. Trastuzumab, and there's one that they give with trastuzumab now called, sounds very similar, pembrolizumab. Does that sound right? Starts with a P and ends with uzumab. Now they're giving both of those together. I don't think they would necessarily ask you to choose that on a test, but just know that if that's an answer, that is okay. That you get both of those together. It doesn't increase your cardiotoxicity. It's not additive. Chemotherapy, right? So remembering that most chemotherapy regimens is going to be doxorubicin, cyclophosphamide, and paclitaxel. These have cardiotoxicities, right? This has cardiotoxicities, so something that you have to be very mindful of. So answering some breast cancer questions. 35-year-old with a palpable breast mass on exam. The mammo has a 2 centimeter mass. FNA is ER/PR, invasive ductal carcinoma. What is your next step? Yeah, right? So talk about radical mastectomy versus lumpectomy with radiation. She would need what after her surgical control? XRT if she chose lumpectomy. What else? Tamoxifen because she's premenopausal, ER/PR positive. What else? Chemo because of the size of the mass. Oops. So what's involved in BCT? We said lumpectomy, sentinel lymph node biopsy, and then don't forget radiation. And then changing your management if somebody has a strong history of breast and ovarian cancer, right? Genetic counseling, and then if she chooses conservative therapy, then she's going to need intense surveillance of that breast and the other breast. Don't forget on the test, when it comes to screening for these mutations, screening for Lynch syndrome, screening for Huntington's, what is going to be your answer to those? Refer for genetic counseling. Because that involves doing a pedigree, seeing if the pedigree is suspicious for that condition, and usually, especially with BRCA, right, you're going to be screening the affected individual first, right? You would be screening her mom that had breast cancer before you would be screening her. Because if her mom doesn't have it, then you don't need to screen all of them, that individual's children. What therapy can you give to treat hot flushes associated with tamoxifen? SSRI, which SSRI is classic? Venlafaxine. How would you screen a patient that has a history of Hodgkin's lymphoma? Screen. How would you do breast cancer screening? I should clarify, because this person needs other screening too, right? Like thyroid and... breast MRI and mammo. So even if you're going that extra step to be doing a breast MRI, you're combining it with a mammo and not replacing the mammo. Premenopausal female has ductal carcinoma in situ. She underwent lumpectomy, then radiation. Her tumor is ER/PR positive. What's your next step? Tamoxifen, right? So she's here in this stage. Positive for carcinoma in situ. She went here, she's here, ER/PR positive, you would treat with tamoxifen. A patient with prior breast cancer treated 3 years ago now comes in with bone lesions. What is your next step? Biopsy. Why are you biopsying it? Yes, because her hormonal status on that biopsy can change over time. So if she was ER/PR positive before, in the recurrence, she could be ER/PR negative. So you need to re-biopsy breast cancer recurrences to recheck. Don't just automatically start treatment again. Next step after a positive sentinel lymph node biopsy, axillary lymph node dissection. Why do we not do that to everybody? It's very morbid, right? You have a lot of issues with lymphedema in that arm afterwards. Breast cancer screening test of choice in patients with breast implants. Right. Right, so this was the trap to see, like, oh, I don't know, is this when I do breast MRI? This is going to still be mammo. Digital per fill. Palpable abnormal area on the breast, right? She comes in, she felt this mass, you feel a mass, you send her for a mammo, it's negative. What's your next step? All right, so you are still going to biopsy this, even though the mammo was negative. So you can do ultrasound. You can see that helps you determine if it's cystic or solid, because if it's cystic, you would aspirate, right? Solid, you would biopsy. Important prognostic factors in breast cancer. Give me 2. Lymph nodes and tumor size. So think about the things that we are giving chemotherapy based on, all right? A premenopausal woman has a 1.5 centimeter mass. She undergoes lumpectomy, and sentinel lymph node biopsy was negative. The tumor is ER positive. What's recommended next? What are you gonna pick from her menu? Right? They tried to sneak in there. She's post-surgery, but has not yet had her XRT. So she needs XRT. She needs tamoxifen because she's premenopausal. She needs chemo because the size of the tumor. Radiation. And then we need to know her HER2 status. That's probably got to be in there somewhere. Postmenopausal female has a painful area on the breast. It's red, warm, and thickened. The mammogram is negative. What are you worried about? Would you say mastitis? Here's some antibiotics. Right, so you're worried about inflammatory breast cancer. Avoid diagnosing mastitis in a non-lactating female. So you're worried about inflammatory breast cancer, and you are going to get a biopsy. Patient has a history of breast cancer 4 years ago. She underwent treatment and she remains on tamoxifen. She had 1 episode of bloody vaginal discharge. Pelvic was normal, pap was negative. What's your next step? Endometrial biopsy because you're worried of her risk for endometrial cancer because she has risk factors of tamoxifen use. A male on spironolactone has unilateral gynecomastia. What do you do next? A, reassure this is just from your medication. B, do something about it. Right? He still needs evaluation. The flip to this is a young boy coming in with gynecomastia during puberty, right? That is going to be reassurance. So, here's our med-peds crew over here. They all yelled out reassurance and something else about pot. Pie could do it too. So going through these, let's go through these a little quicker. So ovarian, remember that there's not a concrete reason to screen for ovarian cancer. Our screening options stink. So for those that you are screening, it is those that are very high risk, such as your BRCA patients who have not elected for a BSO yet. Ovarian falls in this category, right? So ovarian is one where you could send them to treatment, right, i.e. the surgery, before you have a concrete diagnosis in your hands. You have an elevated tumor marker, you have an ovarian mass, you say, I am not going to biopsy this ovary because you do not have ascites yet, and I can now cause seeding and peritoneal implants, right? So this is one where you would say, my index of suspicion is high, I'm consulting gyn-onc, to send you for debulking surgery where they can diagnose you in the OR at the same time as they're treating, right? Do not biopsy an ovary. So early stage, stage 1, right? It's the problems in the ovary. You go to surgery. Middle of the pack stages. Some ascites, some peritoneal implants, right? Surgery with chemo. I think some of this they won't ask you either because there's also some, I think, trials showing chemo first, then surgery. So I think they'd give you kind of the ones on the flanks here. And then really kind of a lot of distant mets is going to be chemo. Know that the goal for surgery is cytoreductive. So doing washing, scraping, taking out bowel if you have to get as much of that malignancy out of the belly. Endometrial cancer, we talked about some of the risk factors already. We talked about starting with an endometrial biopsy for diagnosis. Treatment and staging wise, right? So again, surgery when you're able, right? More distant stuff, chemo and XRT. Cervical cancer, screen, highlight, star, whatever this, HPV vaccination. They're going to want you to counsel patients and parents on the importance of decreasing the risk of cervical cancer, head and neck cancer, all of those. They're going to want you to know the guidelines for screening, right? So starting at age 21, every 3 years till age 65.
For the HPV vaccine, will they be including the new?
I don't think the newer changes would be on your test.
Insurance, some insurances are covering.
Next step for an abnormal biopsy, for an abnormal pap, is going to be colpo for biopsy. So again, stage 1, a leap, right, or a cone resection. Anything over that, you're really going to be starting with more chemo and XRT. Right, so here's surgery. Here it's going to be more chemo, XRT. Testicular cancer is another one that goes over here, right, where you don't need the meat before you treat. So you are going to be sending them based on their testicular mass, based on their beta-HCG, AFPs, to surgery for an inguinal orchiectomy. You're not going to biopsy the testicle. You would seed the more inguinal lymph node beds, right? Because these lesions or a tumor of the testicle will cause lymphadenopathy where? Retroperitoneal, right? Not inguinal. So you're going to have retroperitoneal lymphadenopathy, pulmonary mets, brain mets. It stays midline. Treatment here, right? Remember, there's only 3 stages for testicular. Stage 3 is the metastatic stage. So early stages is surgery. Stage 3, which is metastatic, is chemo. In the middle, it's a little bit different based on the type of testicular tumor. So this is something that they like to ask about because it changes whether the patient would have a radiosensitive tumor or not. So the way I always remember it is I think of a magnet. I'm sure you guys have heard this before. One side is positive and one side is negative, right? It's that bar. So on the positive side is your positive AFP. The negative side is your non-seminoma. So these two always go together. If there is any sort of AFP positivity, it cannot be a seminoma. It is a non-seminoma. So this is how I remember it, because it's just memorization, right? So if there's a positive AFP, there is a non-seminoma. The positive goes with the negative. And then I think of this, and what would this look like if I tried to put it in an x-ray machine and take like a chest x-ray of it? Right, you wouldn't see much. It would be like bright. So you can't irradiate a non-seminoma, right? So this one does not get XRT. Whereas seminomas are radiosensitive. Seminomas never have a positive AFP. Positive AFP equals, say it, non-seminoma. Positive goes with the non. So in your middle stages, right, with all of these, everybody's getting surgery, right, because that's how you're diagnosing it. So everybody's getting an orchiectomy. And then in the middle, your seminomas can get XRT because it's very radiosensitive. Whereas the non-seminomas, these guys, have to get a radical retroperitoneal lymph node dissection and some chemo for those middle stages. And then chemo's the same for both. This is a regimen that you should remember. They call it BEP. They like to ask this question too. Somebody's treated for testicular and they have this residual pulmonary mass. What do you do with that? Do you keep treating it? Their AFP or beta-HCG is now negative. Take it out and resect it. It's probably a mature teratoma, but it has the chance for malignant potential. So they love to ask that question. Age to stop your pap smear screening. Yes. 21-year-old female gets her first pap. She has positive ASCUS, positive HPV DNA. What do you think about giving her the vaccine?
Always yes. Always yes.
Correct. You guys are in clinic too much back there. A postmenopausal female presents with abdominal distension. The ultrasound reveals ascites and an adnexal mass.
Take it out.
Do you biopsy the mass? No. Can you do a paracentesis for the ascites? Yes.
Well, sure. Keep bulk and they'll feel better.
Right? So you could still give her some relief and sample that fluid. That will also share the diagnosis. But you are going to be sending her to surgery. So the paracentesis will give you cytology, but she's still going to need definitive staging and treatment. And never choose the CA-125 when you're asked about a diagnosis question, right? Those are helping you to follow treatment, right? So you're going to be getting it pre-surgery, post-surgery, follow-up appointments, but you're not using that to make decisions. Right? A CA-125 could be elevated just in somebody who has ascites.
Dr. Aller,
Yes.
if the cytology for the paracentesis is positive, is that's bad at that point?
So that's stage 3. Unlike lung cancer, where that fluid makes you stage 4. So in this one, it just keeps you at stage 3. So that doesn't exclude you from being in this conglomerate of treatment, where you can still have surgery and chemo. What is monitored in surveillance following the treatment of ovarian cancer? Correct. CA-125, not imaging, right? So unlike colon cancer, where you're doing colonoscopies and you're doing CTs every year, this one is exams and CA 125. A patient has proximal muscle weakness. These skin findings: high SED rate, high CPK, an abnormal EMG. What's the diagnosis? Dermatomyositis, and the most commonly associated malignancies: ovarian, lung, and breast. Abrupt onset of dysarthria, ataxia, nystagmus, oculomotor dysfunction, associated with small cell, ovarian, breast, Hodgkin's, anti-Yo antibodies. Yo, yes. Young male with cough, weight loss, chest x-ray, has multiple metastatic lesions, testicular exam, has a unilateral mass, or it could have no palpable masses. The AFP and beta HCG are elevated. Your staging CT has pulmonary mets, mediastinal and retroperitoneal lymphadenopathy. What does he have? So what stage does he have? 3. That's the highest you get. Right? He has metastatic disease in the lung. What tumor type? A non-seminoma, because the AFP is positive. Don't even think about beta HCG. Just look at the AFP. So what is his next step in treatment? Orchiectomy and chemo. His chemo regimen? BEP. Following chemo, he has a residual pulmonary mass. Resect. Patient has a renal mass that's being worked up now with increased LFTs. Oh, wait, we're jumping to GU. So going back here, we're going to go through this again pretty quick. For bladder cancer, again, think about it in any patient, especially with a smoking history, who is coming in with hematuria. Early stage bladder is going to be resect. You can give some BCG in the bladder. Later stages, right? Palliative chemo for advanced. Otherwise, maybe surgery or radiation. I don't think they would ask you too much there. Prostate cancer, they're going to want you to have a discussion about the risks and benefits of screening for your patients, and not screen they're going to want you to choose that you're not screening somebody if they do not have a life expectancy of 10 years. Right? So if the options are risk versus benefit discussion, or this patient does not require screening when they are enrolled in hospice for their end-stage COPD, right? So for localized disease, right? So prostate cancer here, it's going to be, you can do surgery, you can do radiation, or you can wait, because those two things come with a lot of complications that your patients may not like. Later stages diseases, your first steps is going to be androgen deprivation therapy, hormonal therapy. Renal cell, there are some perineoplastic syndromes here, so hepatic dysfunction, that gets better when you take out the tumor. Polycythemia, PMR, hypertension, right, a renin secreting tumor. So this one is another one where you do not usually, I'll put here a little asterisk, biopsy the kidney. If you have on imaging something that looks like a renal malignancy, you should just send them to urology to evaluate for a nephrectomy or partial nephrectomy. So for renal cancer, early disease, surgery, late disease, metastatic disease, immunotherapy. I don't think they're going to have you pick between the different immunotherapies. They may just have you pick a class. So remembering things like VEGF, if that's an answer on there for renal cell, or even some of the newer checkpoint inhibitors too. So I don't think they would ask you to choose a therapy among others unless they give you older ones like IL-2 and interferon alpha or a standard chemotherapy type regimen. So renal mass, increased LFTs, CT of the liver's normal. This is what syndrome? If you bought a microwave lasagna from Publix, it would be what brand? Stouffer's. So this is Stouffer syndrome. Resecting the renal mass will make your liver feel better. Oh, sorry. Just pointing out a few highlights in here so we can switch over to endocrine. There's a lot of different types of thyroid malignancies. Remember that medullary is associated with what condition? Men 2, A and B, which is also associated with PHIOs. So keep that in mind when you're mucking around in these patients in the OR. So flipping over just to finish up with cancer of unknown primary, they're going to want you on the test to be choosing the most likely reason for that cancer of unknown primary. Sometimes you don't find the primary, and you just have to use best judgment based on the histology and based on where that was found, right? So in a female who has an axillary lymph node that's positive for adeno, you should treat that as breast. So you're going to be checking an mammo, you can check a breast MRI, and you're going to be doing hormonal status on that tumor. Inguinal lymphadenopathy, that's positive for squamous cell, right? This is not going to be testicular because that goes retroperitoneal. This is going to be anorectal, vaginal, cervical, metastatic or a bony met, right? Adeno or poorly differentiated. Again, thinking about the things that go to the bone. What goes to the bone? P.T. Barnum loves kids, right? Prostate, thyroid, breast, lung, kidney. If you have a male who has retroperitoneal lymphadenopathy or pulmonary mets or mediastinal lymphadenopathy, you're thinking this is testicular. And then finishing this up, really kind of focusing in on a few of these. Avastin or bevacizumab. They like to ask about worsening hypertension once that medication started. The ones that are associated with other malignancies, like bladder cancer here. We talked about endometrial cancer with tamoxifen. Risk of thromboses. Patients that are on thalidomide or lenalidomide for multiple myeloma usually get put on prophy off the bat. I think that is, yes. Oh, that's not in your book?
No.
I could just also send this out. So a 50-year-old female with no past medical history presents with left axillary mass, positive for adeno. Next step. Mammo and your breast MRI are already normal. Where did that come from? Still the breast. So you are going to send her for treatment, removing the breast, doing an axillary lymph node dissection, right? Because you already know she has lymph node disease there, and then you'll find the tumor usually. Man in his 30s, retroperitoneal mediastinal lymphadenopathy, poorly differentiated carcinoma. This is testicular, so you would treat it as a stage 3. A woman is receiving treatment for recurrent metastatic colon cancer with 5-FU, oxaliplatin, bevacizumab, severe abdominal pain, free air under the diaphragm. Which medication could be the culprit? The bevacizumab, associated with GI perforations, AV fistula, aortoenteric fistulas. And don't forget about hypertension. They could have given you that too. A patient has metastatic pancreatic cancer, elevated LFTs, ALK-Phos, Billy. They're itchy. How would you make them feel better? They have metastatic pancreatic cancer that appears maybe to be obstructing. How can they feel better? Yeah, putting in a stent, getting some of that down. A patient has FAP, status post-colectomy. They still need a screening EGD for this malignancy. Duodenal, periampullary. Severe watery diarrhea that doesn't respond to fasting. A VIPoma. Hyperglycemia, weight loss, anemia, a scaly dermatitis on exam. A glucagonoma. Next step in management after surgical resection of papillary or follicular thyroid cancers. Not medullary, not anaplastic.
Iodine ablation?
Yeah, so you can ablate and make sure you've killed off any remaining part of their thyroid left. And then what do you follow for recurrence in these patients? Thyroglobulin, right? That is the cell that holds thyroid hormone. So they should have none of that left after that ablation. So then you would follow that. I think this one's not in your book. Chemotherapeutic agents that you can have that can present with HUS or as a side effect of HUS. Can have a complication of HUS. Chemotherapeutic agent that can present with a flu-like illness, hypo or hyperthyroidism, arthralgias, transaminitis, not used as much these days. Interferon. All right, let's take a break.
Sure, keep going.
You want it? Oh. And then we will finish up endo.